We have Dr. Dana Dunne, who is an infectious disease physician who did her internal medicine chief residency and infectious diseases fellowship at Yale. She works at the New Haven. She worked at the New Haven STD clinic before returning to full-time faculty at the Yale School of Medicine, where she currently serves as internal medicine clerkship director, associate chair of education, and GME Director of Education and of Educator Development. Her clinical focus remains HIV and STI and has served as a faculty member for the Rattel STD Prevention Center since 2001. So, Dr. Dunne, please take it away.
Thank you very much. Nice to be here. I'm sorry I couldn't hear the very beginning of this session today. But I was informed that, as everybody, so if anybody feels a little confused by parts of syphilis, you're not alone. And you've had sessions on syphilis before, but the request was for just kind of like back to basics to kind of slow down over some certain aspects of syphilis. So if you either go to menti.com, which is a website, and then they'll ask what code, and the code will be on the subsequent 2 slides. Or just point your camera at that QR code. The code will be on the next slide as well. I just want to, just get an idea of where to spend my time, because I do have something on all of these aspects, but I can speed up and slow down if you don't understand what's happening with the epidemiology, or if you're having a hard time interpreting blood tests, or if you get a blood test, how do you approach the patient with history and physical in order to know what stage of syphilis they have, and that helps you with the treatment. How do you do? So quite a few people, all of the above, maybe with a little bit of hovering around determining success and failure. The other thing that's going to help me know how to spend some of my time is just tell me in your clinical site, what serologic test do you start with in your setting for screening for syphilis? This will be useful to know how to walk us through some of the testing. So there's 50 some odd of you on, so maybe some of you are not doing the ordering for the blood testing to respond, but still some using the non-treponemal test and some using the treponemal test to start with. Okay, thank you very much for that. All right, so I'll start. That's helping me figure out. I really am passionate about syphilis. I really want this to be, oh, excuse me for 1 second. I'm going to just go back to my slides without making you dizzy, because I want to go back to the beginning slide. But I am passionate about having you feel like you've finished this session understanding more about syphilis, or at least if you've had a lot of experience with it, making you feel better about what you know and kind of just reinforce your knowledge. So let me know at the end of this what still I could do to be more clear about any of the aspects of syphilis. All right, so I'm not going to spend very much time with epidemiology. I'm going to whip over those slides because it doesn't sound like that's a good way for us to spend our time, and you're going to hear more about Connecticut. So I'll talk a little bit about clinical characteristics of syphilis, because I still do hear clinicians trying to respond to a positive serology and maybe not being aware or seeing enough examples of some of the clinical characteristics of the different stages. But then we'll spend more time on testing. And I'll try to monitor the chat, but Linda, you'll let me know if there's something I should stop to see, because I can't always see it at the same time. If I end up using my time correctly, and I don't know if I have an extra 5 minutes now, if we started 5 minutes late, if I can go over, but I do have a few cases at the end to have you apply your knowledge. So here's what we're talking about. If we're talking about patients with clinical syphilis, the prototypic patient coming in with an indurated ulcer that's painless. I think when patients present like this, it may be a little bit more straightforward with respect to the workup and the management. And you may be just wanting to talk more about how to interpret the blood tests, or to follow up. But we'll use this as a starting off point for just making sure that you're feeling comfortable with the differential, and then we can start our discussion about the diagnostics. So I'm gonna just really skip through these epi slides because I want to spend more time where you want to. So you're going to hear more about this in a couple of weeks. So we'll go on to just talking about some of the clinical characteristics. I do want to remind you, though, that here's the organism under dark field microscope, Treponema pallidum, that the reason we end up getting into this conundrum that we have these imperfect blood tests is that we are still hampered by the fact that we cannot grow this in an outside of a rabbit testicle. We can't really send it to the lab for it to grow, and PCR tests, which have really helped us with a lot of other syphilis diagnostics, aren't very sensitive in some sites like blood or spinal fluid. But actually there is a multiplex PCR test that's been developed for quite a while now that tests for both the organism of chancroid and syphilis and herpes simultaneously in patients coming in with primary lesions, which performs really well. And there just hadn't really been a lot of impetus or funds to do more field testing of that in the United States. It's been used a lot in epidemiologic studies outside of the United States, but I'm seeing again more movement about that. So we may, for patients coming in with lesions like on that first slide, have PCR tests within a few years, but we're still otherwise really relying on diagnostics where we could either look at the organism under dark field, which a lot of you don't have access to, or if you happen to biopsy, which we'll talk about. Otherwise, we end up having these blood tests. But, you know, most of you are seeing syphilis transmission in the context of sexual activity, but that can also include deep French kissing. I don't even know if that term is used anymore, deep kissing. And I think one thing a quick pearl to remind your patients about when you're giving them discussions about risk reduction for different STIs, just the reminder that in addition to gonorrhea and herpes, you can transmit syphilis fairly effectively through oral genital contact as well. And so patients who might feel like they're safer because they're just putting their mouth on their partner's genitals might benefit just to remember that that is still a way that they can get syphilis, and they should hopefully be reporting that. And you'll hear more about congenital syphilis. So infectious syphilis is usually when you've acquired the disease within the past year, especially when you have a primary sore or the secondary symptoms, which are more widespread, and the rash. But because our immune systems are not really perfectly controlling the infection after we've kind of healed up our primary and secondary, which I'll go over the timeline, and there could be maybe some waxing and waning of replication during that first year for infection control purposes and partner notification purposes. We really feel like you're infectious within the first year of acquiring syphilis, unless you've been treated, of course. And if you get exposed, it was interesting to hear Dr. Krakauer's talk about you know, what we're able to do when people take doxycycline, and that we can really abort these cases of syphilis pretty effectively. You know, you think about, since it does have a longer incubation than chlamydia and gonorrhea, patients coming in who we screen for chlamydia and gonorrhea, and then we find rectal chlamydia and we give them a week of doxy. It's really interesting to think about all of the incubating syphilis we're probably aborting and avoiding when we do that. But if you get exposed to somebody with infectious syphilis, it takes 3 or 4 weeks before you get one of the primary lesions, depending on where your exposure is, whether that was in your mouth or in the vagina or in the rectum. So when syphilis started to really take off in the early 2000s, disproportionately in men who had multiple male sex partners, and it was kind of concentrated in that group, there was a big PR campaign in San Francisco that was quite caught on, and it was this healthy penis campaign. And this was, I can't remember, he was Phil the healthy penis, and these were these little sores. I used to chase him around town. They'd show up at baseball games and stuff as little mascots. So there was quite a PR campaign, and this poster kind of really says it all with the stages of clinical syphilis. You don't fool me. You know, sores followed by a rash can only mean one thing. So we'll elaborate on that. So we differentiate clinical syphilis into two parts for purposes of treatment, really. And one is that it's early, and that's in that first year, or if it's unclear of duration, or that you know that somebody's probably had untreated syphilis for more than a year. So we will go through the timing, and I'll show you a lot of pictures, because it's important to both be able to think about syphilis when you're confronted with somebody who has one of these lesions or rashes or stigmata, and vice versa. If you are reacting to a positive test, you really want to go in as and focus your exam looking for these things so that you can accurately stage the patient. So either direction. I'm plugging the fact that if you listen to the Curbsiders, that I was on one of the Curbsiders episodes a couple of years ago, that goes through syphilis as well, if you prefer the audio version. All right, so I have this graphic up here in the upper right that I'm going to be using the whole time to kind of march us through the stages of syphilis. So we already talked about the fact that if you get exposed to somebody with infectious syphilis, the incubation period is about 3 to 4 weeks. And, you know, it's not as catchy as trichomonas or gonorrhea, but still about 30 to 50% of people who are with somebody with infectious syphilis will acquire it. So after that incubation period, at the site of contact, you'll get a bump that then will slowly ulcerate. And because of the organism it kind of is called the stealth pathogen. It doesn't really have a lot of things on its outer surface that makes your white blood cells respond quickly. So it's not like gonorrhea that has these things on the outside that recruit polymorphonuclear leukocytes and other acute phase cells that really can irritate you and cause a lot of discharge or purulent exudate. So since it's more of a stealth pathogen, it's not recruiting polymorphonuclear leukocytes, it's more like lymphocytes and plasma cells, and that really is not that irritating, and it can cause some just kind of collagen buildup. So that's why you end up getting this firm lesion that's painless, and that's the kind of ultimate name used to describe the lesion of primary syphilis is a chancre. Sometimes they'll be called the firm chancre as opposed to the soft chancre that we can see in the bacterial disease Haemophilus ducreyi that causes chancroid. So chancre is really this term that we use for a primary lesion of syphilis, which is classically painless. So your differential diagnosis is there. In the United States, the big differential for other STIs would be herpes, which is typically painful and shallow and just a very superficial ulceration. And we have really good diagnostics for that. So in somebody coming in with genital ulcer disease, we would look for both of those. So now I just have a bunch of pictures from some different sites, just to let you know that there's clinical pictures coming. So this is a vaginal, lower third of the vagina is the most common place to see this, which would be consistent with where most penile vaginal friction would be. And then there's a picture of a chancre in the cervix, which would definitely be something that would be not noticed by a patient. And here's a penile ulcer. You can kind of appreciate that heaped up border. It's not undermined. There's no purulence at the base. It's firm. Here's one before it goes on to ulcerate. You can also get multiple lesions. Here's one right there at the introitus, the entrance to the vagina, one a little bit farther up the shaft. And then if you're having primary lesions in your mouth because of oral genital contact, they can be on the lip, they can be more in the tonsil. I remember having a patient in the STI clinic who had a lip one, And he said, it's just like my oral herpes, except it like the other ones went away and this one stayed. And we had a dark field scope in the lab, which was really nice. And that was dark field positive. So you do want to, if you're responding to a primary, to a positive blood test, you do definitely are going to have high yield by looking in the mouth. Here's a perianal area, which could definitely be something that's asymptomatic. So even without any, oh, I should have my little timeline up there, but even without any antibiotics, people may not recognize that primary lesion because it could be in a place they can't see or they can't feel, or they've just thought it was really minor. Without any antibiotics, that lesion will go away. Your immune system does get the upper hand for a little while, but then it, for reasons we don't understand, does not completely neutralize the spirochete. So it starts to replicate again. And 2 to 8 weeks after the primary lesion, and this can vary, it will hematogenally spread. So throughout your rest of your body, it goes very early on to your central nervous system. Even in primary ulcer-based primary syphilis, they've known through research that the spirochete quickly goes to the central nervous system, and you can find it in spinal fluid early on. But secondary syphilis is a stage that's really marked by widespread variety of signs and symptoms. The most common are cutaneous. So 70 to 90% of people will get some sort of rash. You see a range of pictures here of kind of a very widespread rash, but people who've had syphilis before who kind of know the rash or know that they may have been exposed and are kind of worried can come in at the beginning, and they just have a few lesions. So taking a sexual history and doing a blood test at that stage would still be important. So they don't always necessarily make it in the textbook when it's looking less florid. The lesion over here in the this person's forehead it's called Louis maligna. That some of these lesions can be a lot more destructive, and it's really thought that back in the 1500s that all of the secondary syphilis looked a lot like that. That it was actually a lot more virulent, and it has attenuated over the centuries, but you can still see significant lesions like that. And then this picture in the scalp is just showing you the patchy alopecia called alopecia areata that we can see. And I've definitely had patients come in who that's their only sign. We had a new HIV patient who had come in. He presented to an eye doctor with uveitis, but what was really bothering him was the fact that he was losing patches of his hair. So a full reacting to a positive blood test involves thinking about what are the symptoms of primary and looking for those, and all of the symptoms of secondary that can include the rash. Probably classically can involve the palms and soles. And I'm thinking I have some photos about that. I really hope that I do. But it doesn't, about 40 to 50% of the time. So if it involves the palms and soles, you definitely want to be thinking about syphilis. If it doesn't rule it out. But I just want to remind you then back to the mouth. We already talked about the fact in primary syphilis, you can get lesions in the primary lesion in your mouth. But during secondary, even if your initial chancre or exposure was vaginal or anal, when it disseminates everywhere, a finding can be back in the oral cavity, which is called mucus patches. And they can show up on the tongue. These would typically be painless. And they can show up on your lips. So I always have people like evert their upper and lower lip, as well as look in the palate and look on the lateral pharyngeal walls for these kind of almost like snail trails, these serpiginous lesions that you can see that are termed mucus patches. The term mucus patch is also used for a kind of similar looking rash that you can see in the scrotum and on the shaft and in the corona. And we've seen patients who have only presented with a mucus patch on the scrotum. So if you're faced with lesions that look kind of heaped up, or even a little bit like lichen planus and violaceous, sometimes you have to tangentially cross the light. You might need to stretch the skin over the scrotum to kind of eliminate some of the rugae so you can really see some of these. lesions, think about syphilis and think about testing for syphilis. Here's another way it almost kind of looks like ringworm with some raised borders and depressed centers. So those are called mucus patches, and they can be in the mouth or in the genital. Another form of secondary syphilis that can be in the genital area is called condyloma lata. And that's a symptom of secondary syphilis where it's widespread, and it's just the way that the organism is replicating in these moist areas. And so the moist areas are going to typically be more gluteal folds, but typically could be under the breast, but we don't see that as often. It's more perineal gluteal folds in kind of inguinal areas. So the big differential often you'd be like saying, is this warts? And condyloma acuminata, which are warts, are not going to be so broad-based. They're not going to have this kind of whitening that you get from the moisture that you see here, which is why it's called condyloma lata. But if you are looking at a genital area and warts come to your mind, have syphilis come to your mind also. You can see how broad-based it is. And this can be painful. There was a patient that the ID consult service let me know about a couple of months ago in the middle of the monkeypox outbreak, of a woman coming in with painful lesions that looked like this, a little bit more heaped up actually than this middle picture here. And, didn't think so much about syphilis because it was painful, but they ruled out monkeypox. They looked exactly, they had this broad base and they were white. I suggested thinking about syphilis, and she had an RPR of 1 to 256 and got better with penicillin. So Linda, can I just check in? Are there any questions about any of the clinical so far? Let's see. Oh, this is a doxy prep question, so I'll wait on that. So without any treatment at all, so say people don't notice their primary lesion, they thought that they had some sort of viral rash or some sort of clothes laundry detergent rash, and that goes away on its own, even without any treatment. This manifestations of secondary syphilis, which actually I want to add a couple of things to. Other things, their organ systems that you can see involved in secondary syphilis include your liver, syphilitic hepatitis. So if you are reacting to abnormal liver function tests, another thing to have on your differential diagnosis is syphilitic hepatitis. And the clinical pearl for that one is that your alkaline phosphatase is usually elevated out of proportion to your AST and your ALT. Like the alkaline phosphatase will be 800 and your AST, ALT will be in the hundreds, 200s. So think about syphilitic hepatitis. You can also get nephrotic syndrome. So the kidney can be involved. So people can come in with frothy urine or periorbital edema from nephrotic syndrome. And I will come back to this again if I find my slide, because this was definitely supposed to be in here. Early neurologic problems that are symptomatic. So I mentioned that syphilis goes to the nervous system early, and this little kind of arrow that's going across the timeline is just reminding you that the spirochetes goes early and prominently to the central nervous system, but it's usually asymptomatic. But some early symptoms can occur as early as when you're kind of around your secondary, a little before, during, or a little bit after that really widespread disease. And the most common manifestation of symptomatic early neurosyphilis is ocular. Probably about 50% is ocular. And you probably have all seen patients already who have blurry vision. It's usually uveitis is the most common. It can be retinitis. It can be optic neuritis as well, but uveitis is the most common. So I do have a slide just to remind you when we get to the staging of some questions to make sure you ask your patients that look for symptomatic early neurosyphilis as some of the later symptoms that people can have. But ocular is common during this symptomatic early neurosyphilis stage, as well as otic. So sudden sensorineural hearing loss, sudden tinnitus, sudden vertigo, and also you can get facial nerve involvement and headache. So neurosyphilis can occur at any stage. It's not just something that happens late, but some flavors of neurologic symptoms are more common early than others. And the ones that are really inflammatory, the symptoms are due to the inflammation, are the ones that we see earlier, like ocular, otic, cranial nerves, and aseptic meningitis, which would be like a bad headache. So if you don't get any treatment, you will then go into a period of latency, which just means your blood test is positive, but you don't have any illness. And Linda was reminding me that the new terminology for early latent is early non-primary, non-secondary syphilis. And it just means that you're within your first year, but you don't have any signs or symptoms of primary or secondary. And that's an important way for reporting. Or if you've had it for more than a year, or we don't know how long you've had it, it's late or late latent. And there are some, I'm not going to spend time because it doesn't sound like this is important for you right now for understanding syphilis, to know how you could potentially, for purposes of partner notification, purposes of treatment and proper reporting, how you can, what are some ways that you can determine if somebody's within their last year, but they're in the CDC guidelines and listed here. If you can't really confirm that somebody's had disease for less than a year, we treat everybody as if they have late disease, and we'll get to that. So I'm not going to also spend too much time talking about late disease, but we've really eliminated a lot of it with our antibiotics. We still see quite a bit of neurologic disease, especially the early, but there are patients we'll still occasionally see that have cardiovascular late complications, and they can get ascending aortic aneurysms or coronary artery disease from inflammation of the blood vessels there. So this is just a little graphic that outlines what I had talked about, that even early on in infection, most, a high number of people get neurologic invasion. It's a very neurotropic bacteria, but a lot of people presumably clear it out of their central nervous system or otherwise don't have any problems with it. But some people who don't clear it out of their central nervous system can be at risk for sequela, and some is early neurosyphilis and some occurs later. And you just see a timeline from the time of infection of when these different flavors of neurologic complications could come along. I was mentioning that symptomatic early neurosyphilis can really happen within a few months. So certainly within that first year, but things more like stroke syndromes or the general paresis, which is a term used for late neurologic disease, which isn't so much due to the inflammation as it is to the dropout of neurons, and chronic meningitis are really seen decades later. This is the slide I should have had a little bit earlier, that's just outlining some of these entities that we see in symptomatic early neurosyphilis. So I think we covered that. If you're all going to be able to get these slides later on, which I'm really happy to do, if you're interested, this little example is a hyperlink, and it's a great video from the New England Journal of Medicine that's about 7 years ago, of a patient in a London hospital who ended up having some signs and symptoms of late syphilis. And specifically, he had Argyll-Robertson pupils, which are the pupils that accommodate but don't react. So if you shine a light into them, they don't constrict down. But if you have them try to follow your finger as you come closer, that's calling accommodation, they will constrict. So there's a really good example of that. So you can see it in real life, as well as some of the tabes dorsalis, or his posterior column disease, with the way he was walking, his ataxic gait, and his lack of position sense. So that would be fun for you to click on. All right, but let's spend some time. I'm going to just check the chat before we move on. All right, to talk about testing. So 2 different ways that you can find syphilis. One is by directly seeing if you can see the organism, and that would either be because you have access to a dark field scope, or you maybe had somebody with an odd looking vulvar lesion, or they had a skin rash and you were just, syphilis was not on your radar screen, so they got sent for a skin biopsy. You can do immunohistochemical staining and you can find the organism inside tissue. But most of the time we are using blood tests to diagnose, so that would be an indirect way. So we're going to talk about the two flavors of blood tests and how to interpret them. So the bottom line is that no matter what order you use, whether you start with the non-specific treponemal test or you start with specific tests, to make the diagnosis of syphilis and to make sense of it, you're going to be using both of these tests. It's just the order that you use them in that will vary, and that order is really depending on what lab you use and what they've decided to do. So we'll just talk about, just remind you about the characteristics, and then I'll slowly go through interpreting the algorithm. So there are the two flavors, then both of them share that they're really looking for antibodies. The antibodies that are used in the non-treponemal test are not specific for treponemal pallidum, meaning they can be seen and generated to a lot of other illnesses and conditions outside of just syphilis, because it's just looking for antibodies to some things that are in, some things that are in the spirochete coat, but they're also exposed in other clinical situations as well. So there's a lot of other, there could be a lot of reasons for false positive VDRLs, because it can be, and these antibodies aren't specific for syphilis. And depending on your lab, you might be using the Venereal Disease Research Lab test or the RPR. So it's not specific. And so if for those of you who are starting with this blood test, you know that there are a lot of reasons for false positives. So you always have to then follow that up with a confirmatory specific test. But we'll talk about that if you are at those sites that starts with a specific treponemal test. The reason we continue to need both of them is that the RPR or the VDRL tests are the ones that are quantitative. They're the ones that the amount of them in your blood really correlates with how active the disease is. And so it's what we're going to be able to help stage a little bit and most importantly, follow response to treatment. Whereas the specific tests are looking for an antibody that are fairly 100%, not quite 100% specific for T. pallidum. And once positive, they usually always stay positive, with rare exceptions. So they're less useful for new infections if somebody's had it in the past, or monitoring response to infection. Where I think a lot of my colleagues and our trainees get caught up and confused is a lot of the terminology ends up sounding very similar with some of our in some of our algorithms. But historically, we used specific treponemal tests that were manual. If an RPR was positive, they would reflex to the specific test, and these were manual. They took a lot of labor in the lab. And you can see they were either called the FTA or the treponemal pallidum particle agglutination test. And the TPPA, for at least for the last 15 years from the CDC, has been the preferred treponemal test. But because they took so much time in the lab, there had been a lot of call and clamor to try to have newer specific tests that could be high throughput, that could be useful for screening, because most of the screening in the United States is done on people who don't have syphilis. They're done on pregnant women. And so that if you had 10% false positives for every RPR, if you imagine screening 100,000 pregnant women, you had 10% of them, you had to do this manual pipetting. It was really slowing the lab down a lot. So they came up, a lot of companies came up with this automated specific test that could really help with lab throughput. And there was a number of antibodies that are companies that came up with different ways to measure the antibodies. Some was an immunoassay, some of them were a chemiluminescent immunoassay. So there was a lot of platforms that came out. And because there was a lot of platforms that came out and labs were making different choices about which company they were going to go with, a lot of labs, including ours at Yale New Haven Hospital, decided to label them all just treponemal antibody. as a blanket term. But TREP antibody sounds very similar to treponema particle antibody. So you'll hear your colleagues say that TPPA was positive in the screening, and that's really not what it was probably not the screening test anymore. It's the TREP antibody is what we use for screening, but we still use the TPPA in certain circumstances, as we're going to talk about. So before we go on, I'm going to stop for 1 second and share something in the chat with you that you can have to follow along if you want, or just to have as a resource, because this is what I'm going to walk through. And I think it might just be handy for you to have this as a copy. All right. Because it's just really like, how do you interpret the reverse screening algorithm along the steps of the way? So 2/3 of you at least start with treponemal antibody. So that's the new treponemal specific high throughput automated screening test. So really up here, instead of CIA is one of those new ways to do a treponemal specific test, but I could really up here, if you were ordering it from Yale New Haven Hospital systems, and maybe somebody can put in the chat what you call it when you're sending it to the state, but this is just a TREP antibody. This is a specific treponemal antibody. So starting with this new treponemal specific automated test is what we call the reverse sequence algorithm, the RSA. And it's just because for almost all of us, and some of you still, historically, we always started with a non-treponemal test and then confirmed with the treponemal test. So when this new sequence came out, where we're now going to start with the treponemal test, it was the reverse. We still have to use both flavors, a treponemal and a non-treponemal, but we were using them in reverse. So first step is, if your screening treponemal antibodies positive, it's high performing enough that really you can stop there, especially in low prevalence populations like pregnancy. The only thing that I would just caution you here is that if somebody like just comes in and says, I just got exposed to somebody who told me they were just diagnosed with syphilis, if their syphilis is still incubating and they haven't converted their blood test, yes, it can't exclude it. So you would probably want to epi-treat that kind of person if they were just exposed, or have them come back in a couple of weeks to repeat their blood test. But for other kind of routine purposes, you can stop there. So if your screening test is positive, I said you have to use the two together because it doesn't tell you anything about the stage or how long. And there's the next step that the lab will automatically go to, and that will be that it will reflex it to the non-treponemal test. And that could be a VDRL or an RPR. Most places it's an RPR. So this is the quantitative one. And if they're both positive, if the screening treponemal test is positive and the RPR is positive, you have syphilis. Just like you did in the old days where you started with the RPR and your confirmatory manual TPPA was positive. If both are positive, you've confirmed that you have syphilis. You still have to do the work. There's nothing magic about the new algorithm that tells you what stage it is. You then have to evaluate it clinically and stage it. So we'll walk that through in the next slide. If it's negative, then you have a discordance. Your screening blood test was positive, but your RPR was negative. That means they're discordant. So you have to then do a tiebreaker test. Is it discordant because the first one was a false positive, or is there some other thing going on? And again, in most lab settings, the lab already will run and reflex to the next test according to this algorithm. So you don't have to request this, but you should just make sure you know that this is happening and how to interpret the results. So if you have a discordant result, the lab will reflex to the older manual treponemal specific test, specifically the TPPA. And you can see if this is TREP antibody and this is TPPA, how the trainees get really confused about the difference between the two. So if this is also negative, it means this initial test was probably a false positive, which can happen. It can happen, especially in low prevalence populations. So if the initial screening test is positive, but the RPR and the confirmatory syphilis blood test is negative, we think syphilis is unlikely. Again, the only caveat is the same one that's up here, that if somebody's super high risk and they just got exposed, you would maybe want to repeat it in a couple of weeks. But I think the majority of our patients, when we're going through this algorithm, we can just say that the first one was a false positive. So the last thing I'm just going to uncover here is if it's positive, then you have 2 treponema specific tests that are positive, but why is the RPR negative? Why was that negative? So there's 3 possibilities. One is that it's very early syphilis, because we know the treponemal tests do become positive before the non-treponemal tests, about a week earlier on average. So it could be early syphilis. So that depends on the sexual history of the person when they were exposed. But the most 2 common reasons are B and C, is that either they had syphilis treated in the past, and like we said, the treponemal test will stay positive for life. So, or they have past untreated syphilis. And the way you differentiate between those 2 is to ask the patient if they've ever been exposed to syphilis or treated for syphilis. They usually know, and your friendly hosts that are sponsoring this talk are the ones that you can call up at the state. 860-509-7920. I always have that number in my mind. Hopefully it's the same one, and you'll make sure you have it. I'm sure you all have it. You can call at the state and confirm if somebody's been positive before for their syphilis blood test. And you can confirm that they've been treated, and that would be B. And if you can't confirm they've been treated, then you have to make sure you stage somebody appropriately, and that's what we're going to go to next. So
Dr. Dunne,
yes,
we do have a question in the chat. What is the tiebreaker for labs using the old algorithm, BDRL and T?
Okay, so there's no need for an older, well, I should say, in that situation, the TPPA being a manual test and having such good test performance, if the RPR was negative, I'm sorry, if the RPR was positive, that's why you would have reflexed to the TPPA. So we feel like if the RPR was positive and you reflexed to the TPPA, it's such a good test that you don't need to do a tiebreaker. The automated test is not as perfect as the TPPA. And that's why we kind of keep the TPPA as the gold standard. So you don't need another test. And and you wouldn't have done the TPPA to start with if the RPR had been negative. So in rare circumstances, like say pregnancy and maybe medical legal situations where it's really high stakes to make sure that TPPA can be the gold standard, people have sent blood to the CDC for a Western blot. They've sometimes done that. They sometimes are not doing that, depending on how busy they are. But otherwise, whoever asked that question, let me know if that answers it. It's such a high functioning test, that manual specific test, that there's no tiebreaker.
And we actually do have another question.
Rapid point of care. You know what? I might put a pin in that just to make sure I get through this.
Yeah.
Okay. So just to remind you then,
Will do.
If you have your 2 tests that are positive, you're concordant, you then have to do this work to stage it. So that's when you're going back to those slides to remind yourself of all the places you have to look for primary, and the questions to ask them about if they've had problems in those areas or seen things in those areas that might not be apparent to you. But you can't just sit there and say, do you have any symptoms right now? And they say no, and you mark them as latent. You really do need to do the job, because they might not notice stuff in their mouth or stuff in their genitals, and there's implications for our disease intervention specialists who are going to be going out to try to find partners if we know that we could accurately stage them with earlier versus later syphilis. So really wanting to take a good history and physical, and I do have one sheet that they use in Seattle to kind of prompt providers to ask about some of these neurologic symptoms as well. So you want to make sure you stage them appropriately. Either you find that they have primary, you find that they have secondary, or you find if they really have nothing at all and you can't prove that they had gotten it in the last year. If they get yearly syphilis serology because they're in care for HIV, then you can probably presume that it's early and treat them as though it's early, non-primary, non-secondary. But if you can't prove it, we just presume that it's late, that they've had it for more than a year. You want to make sure you're testing everybody for HIV, and then you're going to treat them based on the treatment guidelines. And that's, as I'll show you in the next slide, is either that they have, you're treating them for early syphilis, which is primary, secondary, or within that first year, or that they've had it for unknown duration or more than a year, and that's a different treatment. And then don't forget about partner notification, and then I have a quick slide on follow-up. So this is just really reminding you of things that help you with staging, because if they've not had any sex with anybody, including oral, and you have to make sure you ask about that for more than a year, that's going to help you with your staging. And then we talked about kind of where to look. This is that sheet that they had developed in Seattle to help the practitioners who are either having patients coming in with these concerns and making them think about syphilis, but more often new HIV patients coming in and they're found to have a positive syphilis blood test. In addition to doing that exam that they're asking about symptoms of otic syphilis or ocular syphilis or neurosyphilis, and remembering that some of them, they really need to, if they have ocular or otic, go quickly to see specialists, because especially for ocular, a rapid diagnosis, confirmatory diagnosis, and starting treatment can really be vision saving. So it's useful to have a checklist like this in your clinical setting. So you're less confused about treatment, because I do think it is straightforward, but you have to make sure you've staged appropriately in order for you to be accurately applying these treatment recommendations, which is early syphilis, which is primary, secondary, or early non-primary, non-secondary. In that first year is 1 shot of penicillin or 2 weeks of doxycycline if they have an allergy, and penicillin is preferred. And if it's later, then they get 3 weeks of benzathine penicillin or 28 days of doxycycline if they have an allergy. If they're pregnant, doesn't matter what stage they're in. If they're pregnant, they get treated per the stage, and the CDC guidelines have a really nice treatment of how to think about congenital syphilis risk relative to the stage that the mother's diagnosed, and how much treatment and serologic response she can have during her pregnancy, depending on when she's diagnosed, and how to evaluate the infant. It's very complete. But you want to use penicillin and not doxycycline during pregnancy. So the correct answer, if they're allergic, is that they have to get admitted and desensitized to penicillin. They're not allergic, you're using penicillin per the stage, how you've staged them. But if they're allergic, you can't use doxycycline, and they need to get desensitized or work with an allergist to try to characterize their allergy. Anybody who's got otic syphilis or ocular syphilis or any kind of neurologic involvement gets intravenous penicillin. And you can do this without admitting somebody to the hospital. Just get a PICC line in, give them their first dose in your infusion center. And then later disease, we treat for longer. And I think you're not seeing that quite as often. So I just want to talk about follow-up serology, and some people marked the box, and then we'll almost be done, for knowing if you've been successful or not. When you've made the diagnosis of syphilis and you've treated it per the stage, how often do you repeat the blood tests? For people who don't have HIV, it's recommended that we follow the non-treponemal titers every 6 months, and then we'll talk about how quickly they should go down. If they're HIV positive, we do that more frequently. So every 3 months, we're following their titers and wanting to make sure they respond to therapy. Treatment failure is a little bit more common, but not well understood in HIV infected patients. So how do we diagnose a treatment failure? So you diagnosed and treated them according to their stage. You're following the blood test. And I've got a flow diagram after this one that has a little bit more detail. So the definitions of treatment failure would be that they have persistent signs and symptoms. So they had a rash that's not resolving, or they have a headache that's not improving, or a facial droop that's not responding. So if they've had treatment failure symptomatically for more than 2 weeks, The least controversial definition of failure is their non-treponemal titer has gone up fourfold or 2-tube dilution from the treatment titer. So you treated them at 1:16, and then you see them 3 months later, and they've gone to 1:128. So that's clearly a treatment failure. So if you hadn't checked an HIV before, they suggest rechecking one in case that was not done the first time. And they do recommend doing a lumbar puncture in case there's evidence of neurosyphilis. And that's one of the reasons why they might have failed, because the treatment wasn't eradicating under-recognized central nervous system involvement. If those are unremarkable, they just suggest you retreat. What's less clear is people who don't decrease adequately. So I think on the next slide, I have the definition of what is thought to be as adequate. So appropriate is a fourfold decline after waiting a full 12 months if you've treated somebody in the early stages, that first year, so primary or secondary or early latency. So you want to wait a full 12 months. And if it hasn't come down fourfold, or if you diagnose somebody when they had late syphilis, that they didn't, and you wait a full 24 months. So if they've had a lack of decline, you again want to ask about neurologic signs and symptoms. And if they have them, you definitely want to immediately do a lumbar puncture. And if it's positive, then meaning if they have more than 10 white cells, or if their spinal fluid BDRL is positive, then you treat them for neurosyphilis. But if it's negative, you've ruled that out, and you would probably just retreat. That's shared decision making. If they don't have neurologic signs or symptoms, and they've just had this kind of incomplete response, again, you always want to say, could the patient have been reinfected? Is the reason that they went from maybe 1 to 32 down to 1 to 4, and then they're 1 to 8, and they kind of stay there, and you're not clear. Did you get re-exposed? Have you been sexually active in the meantime? And if they had, treating for the possibility of reinfection with 1 dose of benzathine penicillin could be done, and then you continue to follow them. But if they hadn't been reinfected, just continuing to wait and seeing if they just continue to slowly go down over time, and talking about the shared decision making. And if we have time, we could talk more about what the shared decision making would be. And I already said that if it goes up, it's a little more straightforward if the titers go up. If they have neurologic signs and symptoms, you definitely are wanting to do your LP. If they don't have neurologic signs and symptoms, if they don't seem like they could be reinfected, but their titers are going up, most experts would recommend doing an LP in that situation. So this is just nice maybe to have at your desktop to work through. I think a lot of people just don't wait long enough before they decide if somebody's failed or not. All right, I know that we're at time. I think I'm just gonna, probably somebody will talk about partner notification, but I do think that partner notification is something that a lot of practitioners don't know about, but you all know about partner notification and reporting. So maybe I'll just stop, and so we could see if we have any questions. If people wanted to stay over the 5 minutes, we could do a couple of cases, but it might be more important to see what questions people have.
We have like 1 minute for questions. And then we have some wrap up information for everybody. So if you have a question, you can ask it now. Otherwise, if you would like, we could follow up. If you have a question, you can send it to me, and certainly Dr. Dunne would be able to respond. Maybe we could just touch on the rapid point of care that did come up, if you wanted to comment on that, Dr. Dunne.
Yeah, does the person who asked that question, are they using that, or if they could talk about the context?
Can you hear me?
Yep.
Okay, hi, this is Sally Hellerman at Planned Parenthood. We're not using it, but the reps are trying to convince us that we should start offering it in our health centers.
So, and Josh is using it. Yeah, and they've been used for quite a while in developing countries, and they're quite accurate. And to be honest, I feel like I need to make a table now that would talk a little bit more about, how to use that in conjunction with your testing. But like they said, both the PCR that I think will also really help the field testings of the PCR on lesions had help, is pushing the idea that there's going to be able to be earlier diagnosis of people who might have lesions that are consistent with syphilis. But just being able to have access to the point of care test gets you faster results. But I don't have the comparative statistics in my mind about test performance and any confirmatory tests that you might feel like you have to do.
This is Josh.
Yeah.
Yeah, so we actually just had a case where this was an individual who we weren't able to do venipuncture on. So that's where we're primarily using it. Also with patients where we feel there's a high likelihood that they will fail to return if treatment's indicated, and where we've linked them to other cases via DIS, we'll do a rapid. Obviously, it's only useful if we know they have no prior history of syphilis, but we have had cases just recently where we otherwise would have missed it, and we were able to treat that individual the same night. We've had several other cases where they were likely going to be lost to follow-up. In fact, they were lost to follow-up, but we were able to treat them as a result of having the rapid test. The biggest challenge with it is the cost. It's about $20 per test.
Yeah, but it's good to know that it's starting to get out there, because I think this is going to come up more, and just having some clearer idea of, in what population and how it performs in that population. And
yeah, we're almost exclusively MSM, our population. The biggest challenge, aside from the cost, actually, is that such a high percentage of our patients have a history of syphilis already. So we obviously can't use it in that case, but we've been using the rapid tests now since 2016.
Okay, great.
Thanks, Josh. Thank you so much. Well, unfortunately, we have run out of time.